Good evening and welcome. I'm James Liu, and I'm a librarian at Stanford Health Library. Thank you for joining us for our talk, The Mysterious Headache, CSF Leak. It's my pleasure to introduce our speaker, Dr. Ian Carroll. In 2015, Dr. Carroll collaborated with Stanford's Neuroradiology and Neurology Headache divisions to create the Stanford CSF Leak Headache program. This was after his daughter had suffered through an initially undiagnosed CSF leak. The experience left him with a passion for helping patients experiencing CSF leak around the world. Dr. Carroll is board certified in 4 different specialties: in headache medicine by the United Council for Neurologic Subspecialties, in addiction medicine by the American Board of Addiction Medicine, in pain medicine by the American Board of Anesthesiology, and in anesthesiology by the American Board of Anesthesiology. His primary focus is on spinal cerebrospinal fluid leaks. Dr. Carroll has spoken at numerous national meetings on CSF leaks, on management of the pain from nerve injuries, and on factors influencing opioid cessation. He has conducted visiting professorships at Johns Hopkins University, Vanderbilt University, Yale University, University of California at Davis Medical Center, and others. In addition to his clinical and research responsibilities, Dr. Carroll helps select and train Stanford anesthesia residents, pain management fellows, and neurology headache fellows. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen. And at the end of the talk, Dr. Carroll will answer as many of those as possible. Over to you, Dr. Carroll.
Thank you. In 2016, I gave a talk here at the Stanford Health Library on the mystery headache, an explanation of what spinal CSF leaks were and what we understood about them. And so I was pleased to get an invitation from the Health Library to come and provide an update to what we knew then and what I think has been important in the interim. For those of you who don't know me, I work at the Stanford Neurology Headache Clinic, and I'm part of the anesthesiology department at Stanford. I've been fortunate in that in the time since my last talk here, we have been doing work supported by the Considine CSF Leaks Fund, but I have no other disclosures. Many of the articles I'm going to talk about during this talk are included in a Google Drive folder that this QR code links to. This is what's called a dynamic QR code, and so over time it can be adjusted to include more and more resources for people coming and watching this video. And so it will continue to include the papers discussed in this talk, contact information compiled from Stanford and Duke and others on physicians who are interested in helping patients with CSF leak, our own imperfect MRI imaging protocol, and more data on CSF leaks and how to get help if you're worried that you have one, such as how to reach a physician who you might want to see. The cerebrospinal fluid, shown here in white, surrounds the brain and the spinal cord, and it provides buoyancy to the brain. The brain is made of fat, and it floats in water, and the CSF essentially has the density of water, and so the brain inside your body is floating in its own little swimming pool. And the buoyancy provided by the CSF reduces the weight of the brain effectively by about 96%, from over a kilogram down to just 45 grams. And that spinal fluid buoyancy is a critical function. The CSF down in the spine is contained by a watertight connective tissue called dura. And the important thing to understand, the dura shown here in white has spinal fluid contained under pressure inside. And this dura can be punctured by a sharp edge, such as a needle wielded by a doctor trying to do something, for instance, like an epidural to help a patient. Or it can also spontaneously tear, even without trauma. This dura can tear sometimes, and it can leak into one of two places. It can leak into the space outside the dura, called the epidural space, or it can leak into a vein. You can see that there's all kinds of blood vessels around here, and if the dura in fact tears and leaks into a vein, the CSF can start to escape into the vein, and it creates what we've come to understand and call a CSF venous fistula. And so I'm going to be updating my talk from 2016 to specifically talk about, first, what we've learned about how needles that we doctors use to try to help patients can sometimes lead to chronic problems of CSF leak. And then I'm going to talk some about what we've learned about the limitations of how we've previously diagnosed CSF leaks, the limitations of MRI, the limitations of opening pressure, and some of the hope conferred by our increasing ability to detect and diagnose those leaks that are into a vein, those CSF venous fistulas. I think before jumping into that, just to recap some of what I talked about in that 2016 talk on the Stanford Health Library. When the CSF escapes and the spinal fluid starts to leak out, the core symptoms of a CSF leak are headache, most typically a postural headache, where the headache is worse the longer you're upright and better the longer someone is flat. We have come to understand in the last 5 years, there's now good publications documenting this, that the longer you have a leak, the more subtle and less obvious that postural change can be. So when a leak is new, you're more likely to have a very clear postural component to head pain, where you feel better pretty quickly when you're down and worse when you're upright. But that orthostatic or postural component becomes progressively less prominent over time, and it can be your head pain doesn't totally go away when you stay flat, or you have to stay flat for a very long time for your pain to get low. And it's clear that some people don't have a postural component to their head pain when they have a CSF leak. I think what's most typical, not universal, but typical of the head pain from a CSF leak is almost invariably the patients who have it describe it with the word pressure. They often take pains to tell me that it's not pain, that it's pressure. They will often feel a component of the pressure, or a pulling or pressure at the base of their skull or the top of their neck. It almost never is unilateral, as a migraine would be. It's almost always on both sides. And it rarely presents with headache-free days. They're, unlike migraine, where people will have headache days and non-headache days, my patients with CSF leaks are really suffering pretty much every day. And it's not just the headache. They feel profound fatigue, profound neck pain and stiffness. Often they're nauseated every day of their life. They may feel a sense of imbalance, as well as vertigo or ringing in the ears, because the spinal fluid connects to the inner ear fluid, and alterations in pressure of spinal fluid get transmitted to alterations of pressure in the inner ear. And people get those symptoms: vertigo, dizziness, ringing in the ears, and often a sense of fullness, like they need to pop their ears. And then finally, there's often kind of hard to pin down neurologic symptoms. Patients will have a sense that they can't quite concentrate, they can't remember things, they'll have difficulty with word finding, they just don't feel mentally sharp. The students who I see will tell me that they were A students and now they're having trouble, often having trouble really passing. So a really profound set of symptoms. It's not just a headache, it's a whole syndrome. And it often gets diagnosed, because it's hard to recognize, it can be diagnosed as chronic migraine. It can be diagnosed as new daily persistent headache. If it occurs after a trauma, imagine someone gets in a bad car accident and then they start having head pain and difficulty with memory or concentration, and they're having chronic nausea. They might get diagnosed with post-concussion syndrome. If they're a young woman and the symptoms of postural dizziness are really prominent, and especially if they have a degree of their heart racing, they may get diagnosed with postural orthostatic tachycardia syndrome, or POTS, which can be hard to distinguish from a CSF leak. So it can really be diagnosed as many different things, but the core is that they have multiple symptoms in these multiple domains, and they're really debilitating. So one of the things we've learned over the last 6 years and has become more widely appreciated is the contribution that well-meaning and attentive and careful doctors are nonetheless contributing to this. So myself and other doctors, when we're trying to do what's called an epidural for a patient, either an epidural steroid injection or an epidural to put local anesthetic outside the spinal fluid for pain relief, for instance, when a woman is in labor, or when an epidural catheter is placed for pain control around the time of surgery, we insert a needle like this into the back. Here we've illustrated the spinal fluid as blue just to make it a little more visible. And when you're trying to do an epidural, you go ahead and you advance the needle right up to the outside of the bag of fluid. And the dura here is illustrated in yellow. And the goal is to put your needle right outside that yellow barrier, that dura. And then if you inject if you inject local anesthetic, as it surrounds the bag of spinal fluid, it creates numbness and people can get profound pain relief. And millions of people have had relief from epidural injections, including probably the most common use of it today is epidurals for labor pain relief. Now, the problem is nobody's perfect. And the difference between what I just showed you and accidentally putting that needle into the bag of fluid is a matter not of inches, but of millimeters. And when you do this, you create a little rent in the dura. And when you pull that needle out, the spinal fluid can start to leak out of the bag of fluid. Now, it doesn't leak out of the body. It gets resorbed in these tissues behind that yellow barrier. But what happens is, as that spinal fluid leaks out, the fluid that had been surrounding the brain starts to be reduced, and the brain can actually start to sag a little bit in the skull. When it sags and it starts to dip beneath the opening in the bottom of the skull, called the foramen magnum, as the brain starts to sag through it, it can actually mimic a condition called Chiari, where the brain is also sagging at the bottom of the skull. And it can be very hard to tell the difference. And one of the things that, if a patient's wondering, is their brain sag a Chiari, or could it be a subtle sign of a leak? One of the things that should be done, that's easy and doesn't require expensive testing, is to spend a prolonged period of time flat. Chiari symptoms should not get better when you stay flat, but many leak symptoms will. And so, for instance, someone with a leak, after staying flat all night sleeping, will often feel their best in the morning before they get up to go to the bathroom. And then once they get up, they start having the resumption of their symptoms. And they may attribute that to a circadian rhythm, noting that late in the day things are a problem, but mornings are always better. And the way you can distinguish between it being a circadian rhythm problem or a posture problem is, instead of getting up and starting your day, you can spend the day flat. And sometimes we will ask patients on the weekend to spend a whole day or a day and a half flat, what we call a 48-hour flat test. But when you create a leak, as I was showing with that needle, and the spinal fluid starts to leak out, patients do get this kind of CSF leak headache. And it has long been appreciated that that is the consequence of creating a dural puncture. But what really wasn't well appreciated until the last 10 years, and increasingly even the last few years, is the propensity for that kind of dural puncture, not just to create a headache in the first couple of days or week after the puncture, but that many of these patients will go on to have chronic symptoms. So this paper was published in the journal Anesthesia and Analgesia by one of my colleagues here at Stanford, Pam Flood. And in that, they examined 40 cases of women who'd had an accidental dural puncture when they were having a labor epidural, and compared them to 40 control patients who had had an epidural for childbirth at the same day, same hospital, but they didn't have an accidental dural puncture. And what Pam Flood did that was different than many of the studies before is she and her team contacted these patients 12 to 24 months later and asked them if they were having new chronic headaches, and simply measured the frequency with which that was happening. Among the group that had an accidental dural puncture, almost a third of them were still having new chronic headaches roughly 12 to 24 months later, compared to only 5% of the control patients. This was highly statistically significant, meaning it didn't arise from chance. And I think it's important to look at this and realize that the amount of new chronic headache that we can attribute to just the problems of having had a baby, for instance, the sleeplessness, the sleep disturbance, the hormone changes, that only accounts for 5% of new chronic headache in young women who've had a baby. But if they had an accidental dural puncture, the likelihood of having new chronic headaches is 6 times higher. And we're not talking a week afterwards, we're talking a year to 2 years later. These are women who have a new chronic problem directly attributable to the doctor trying to help them at the time of their delivery. It does not imply that the doctor did anything wrong. It's just a result of accidentally puncturing the dura. What you see is if they were treated with a blood patch for their accidental dural puncture, a procedure in which the doctor injects some blood over the leak that they just made into the epidural space outside the bag, again, an epidural blood patch procedure. If they were given that epidural blood patch procedure, the rate of having new chronic headaches is essentially cut in half. Patients who were treated conservatively had a 40% chance, conservatively meaning they weren't given a blood patch. They were told to rest, stay flat. When they were looked at a year to 2 years later, they had a 40% chance of having a new chronic headache. In comparison, those who were offered a blood patch in that first week after having had a delivery and an accidental dural puncture had a 50% reduction in the likelihood of having that new chronic problem. And this is, I think, a strong argument for treating these accidental dural punctures aggressively. It may really prevent a long-term problem. And that's something that neither the anesthesiologist nor the patient is often particularly enthusiastic about. If you've just had an accidental mishap from an epidural, the patient rarely wants another needle in their back to try to address the problem from the first needle. And similarly, the anesthesiologist, knowing that, excuse me, my light's gone out. Very good. Similarly, the anesthesiologist is not so thrilled about the idea of sticking another needle in there, knowing that they are quite expert at doing an epidural, and they accidentally caused a dural puncture the first time they tried to put a needle in there. They're worried that maybe there's something different about the anatomy that is conducive to accidentally puncturing the dura. And so there is both a crisis of confidence on both sides of that needle, the patient and the physician, and a desire by both to avoid putting another needle in. And yet this data would suggest that putting another needle in there and patching the sites where the accidental dural puncture was made is exactly the right thing to do and an important intervention to prevent a long-term problem. That data has now been reproduced. This study by Ranganathan and colleagues in 2015 compared 308 patients with an accidental dural puncture to 50 controls who had an epidural without the accidental dural puncture. Like Dr. Flood's data, you see that the rate of headache was about a third in the patients who'd had the accidental dural puncture. Among the controls, only 2%. Also, the patients who had the accidental dural puncture, much higher rate of chronic back pain compared to controls. In addition to those two retrospective case control studies, now in the journal Headache, in 2018, a prospective study looking at 45 patients who had an accidental dural puncture, and they followed them out over 18 months and similarly found that about a third had new chronic headache, new or worsened chronic headache. And so they concluded that a post-dural puncture headache from an accidental dural puncture can no longer be considered a self-limiting condition. This has been noted in other papers over the years. And it's important because epidurals are employed in this country en masse. The CDC reports that 3.7 million births per year happen in the United States. 60% of those will have an epidural. So that's 2.2 million epidurals per year. If just 1 or 2% of those epidurals have a recognized dural puncture, which is the current estimate, that will result in 33,000 new doctor-caused chronic CSF leaks per year. 33,000 is the number of accidental dural punctures. And if a third of those develop new chronic headaches, that's 11,000 new chronic headaches per year. So why does this happen? Why does it lead to a chronic problem? Well, one cause is what we call a dural bleb, and that's shown here. So this patient had a spinal cord stimulator put in, very similar to an epidural. And when they put it in, they accidentally punctured her dura, and it led to this little bleb here, which is now next to the stimulator, so that the dura here, it didn't just heal and go back to the way it was. One of the inner layers has kind of ballooned out through the outer layer, and it's containing the contrast that's been injected in the CSF here in a myelogram. And so there's this little bleb. It's like a little balloon coming off the old puncture site, and it can't contain the spinal fluid pressure. That's what it looks like, a little bigger. This is another woman who had an accidental dural puncture with a labor epidural needle. She's now had a myelogram, so contrast has been put in her spinal fluid. This would be the floor, and so the contrast is denser than spinal fluid, so it's kind of layering here. And because it's layering, a teeny little bit has filled this bleb. And you can see that the dura, it hasn't gone back to the way it was before. When we talk about it healing, sometimes it heals with a permanent anatomic difference that leads to its structural weakness. That's what it looks like when we look in another plane. So sometimes that puncture leads to a bleb. And again, that's what it looks like here when the back has been opened up to do surgery on the dura. And now you can see somebody has put a little purse string into the dura to close that off. Another cause of the persistent problems when this happens is what we call a ventral dural puncture. So a doctor putting in the needle doesn't just puncture the back of the bag of fluid here, but goes through and through. Illustrated here. So they're coming in from the skin of the back, they go in, they penetrate the back of the bag of fluid, and then they penetrate the front of the bag of fluid. And when you do a patch, sometimes the patch only covers the back surface. This is an image published by my friend and colleague, a maven in CSF leaks, Wouter Schievink, down at Cedars-Sinai in LA. He published this as an image in his review in the journal JAMA in 2006. And you can see the blood patch done here to fix the leak, it only covers the back surface of the bag. Here's the bag of fluid. Here's the spinal cord in there. But you can see if your problem is in the front of the bag, putting fluid back here or patch back here isn't going to help. You're going to have to put something in the front of the bag. So an illustration of that happening is for this patient who presented at Stanford last year, an 18-year-old woman who'd had an epidural placed at an outside hospital. They accidentally punctured her dura. They had tried to give her a patch twice without success. And by the time she got to Stanford, you can see that she has blood collecting on the outside of her brain, a hemorrhage here called a subdural hematoma that happens when there's not enough spinal fluid. And it's pushing on her brain. It's pushing the midline of the brain over to the other side. And this is what her MRI of her lumbar spine looked like. So this MRI is done in a way to make the bag of fluid, the water in the spinal fluid, look really bright. And so you see a teeny little brightness here outside the dura, but what you really notice is that in the front of the bag is this collection of fluid. And so that's that ventral collection. The back of the spine is back here. So someone has gone with their needle and not only punctured the bag, but gone through and through and punctured the front of the bag. And you can see that there on the what's called the sagittal image. And the important thing is, by the time she came to Stanford, she'd actually had this problem for a couple of months. And so we thought that that there's a hole here, and that hole is going to probably not even be very fixable with a patch, and that surgery to close this was probably more important, especially given that she was bleeding in her brain. And so we needed to be able to tell our neurosurgeons where that leak might be. And so we used a technique called a digital subtraction myelogram, where we put a needle in the back here and we inject contrast into the bag of spinal fluid, which you can't see on X-ray. You can only see the bones on X-ray. But once you inject the contrast, if you use a technique called digital subtraction, the first image as you inject the contrast, this whole image is digitized. And then for every subsequent image, the things that are the same in all of the images are digitally subtracted out. So we call it a digital subtraction myelogram. And what that looks like is this. So you can see a teeny little hint of that needle coming in, but now the bones are really hard to see. They've been digitally subtracted away. And the only thing you see is the contrast, which has been injected, which is new as you get more and more images. And you can see that contrast spreading here. And then what you see is the contrast layering out inside the bag of fluid. And if you look carefully, you see that little thing, a little bit of contrast escaping right there from the front of the bag. And if you get another image a second later, it looks like that. And so that's a technique that was developed and really popularized and taught to us by Wouter Schievink and Marcel Maya, again at Cedars-Sinai. But this allowed us to find this hole in the front of the bag and allow our neurosurgeons to fix that. And the last reason why some of these people go on to have chronic problems is what we call a dural fistula, shown here again by someone had a doctor stick a needle through here, and they developed a chronic leak. And you can see here this little hole. And it's not a little raggedy hole, it's healed in that open state. The edges have had cells grow around them. It's not trying to heal anymore. It's just healed with a opening of the bag. So fluid's just going to keep dripping out of that forever until some surgeon comes and sews that shut. And so I've shown you 3 reasons that we now understand contributing to why a needle in the back can lead not just to an acute problem that we call a post-dural puncture headache, but lead to a chronic CSF leak. I showed you that it can lead to a bleb. There can be a ventral puncture that's hard to patch, and you can have this kind of fistula. And all three of those things are things we've now seen contributing to people having long-term headaches, often worse the longer they're upright, after having had an accidental or unintended dural puncture during an attempted epidural. And what makes that even harder is that we don't know what % of accidental dural punctures are not really recognized at the time that we do an epidural. And it turns out it's a hard thing to figure out. So I told you that the CSF is contained by this watertight dura and that it could be punctured by a needle. We've talked a little bit about that. But the dura can also leak without trauma into two places, the epidural space that we talked about outside the dura and into a vein, creating a CSF venous fistula. These are what are called, because they happen without trauma and without the help of a doctor with a needle in his hand, we call these spontaneous CSF leaks. And for a long time, we've used brain MRI to screen for CSF leak. The classic findings on a brain MRI that the lion's share of radiologists in the world look for when they're trying to tell if somebody has a CSF leak is this thick white covering lighting up on the MRI, what's called pachymeningeal enhancement. And it is a good indication that somebody has a leak. When it's thick and smooth and circumferential like this, there is almost nothing else that will cause this appearance. This appearance means somebody has a spinal CSF leak somewhere. And that's great, but it's actually not what I usually see. So this is much more characteristic of what I usually see. This is a young woman who I first saw in 2016 when she was 21, complaining of daily headaches. She had been diagnosed with POTS, or postural orthostatic tachycardia syndrome. She had severe daily nausea and had been diagnosed and followed by the GI service here at Stanford for gastroparesis. And she had an unexplained chronic elevation in the hormone called prolactin, which has been reported to happen in some patients with CSF leak. But her brain MRI didn't show that pachymeningeal enhancement. And because it didn't show that pachymeningeal enhancement, her brain MRI was read as normal, no evidence of CSF leak. Now, the question then becomes, if in fact that pachymeningeal enhancement only is seen really with a CSF leak, how often is it there in CSF leaks? So we only see that kind of pachymeningeal enhancement when someone has a leak, but what percentage of leaks don't have that? We don't really have a great bead on that because we need some kind of way of determining when someone's imaging is negative, do they still have a leak? You need some gold standard to compare the imaging to, and that, it turns out, has been pretty hard to come by. One approach to this was illustrated by this group out of Japan, who looked at 250 patients who were suspected of having a CSF leak based on having an orthostatic headache, meaning they had symptoms, headache symptoms that were better when they were flat and was worse when they were upright. And they then gave them a test called a radionuclide cisternogram that has, it can be criticized for a number of things, but it's an older kind of test that was used to look for CSF leaks based on having an injection of a radioactive substance into the spinal fluid and then looking for evidence that the CSF and the radioactive tracer it now contained was getting out of the bag. So they looked at those 250 patients who had the right symptoms, orthostatic head pain, and found that 186 of them had evidence of CSF leak on a radionuclide cisternogram. Now, when they looked at the brain MRIs of those patients, what they found was only 21 out of the 186 had any evidence of brain sag on the MRI. And of those 21, only one patient out of the 186 who had a positive radionuclide cysternogram, and only one patient out of the 250 who had the right symptoms, 186 of which had a positive radionuclide cysternogram, and 21 of those also had a sagging brain, but of those, only one had pachymeningeal enhancement, suggesting that the pachymeningeal enhancement may truly indicate a CSF leak when you see it, but just be an awful way of determining that someone doesn't have a CSF leak when you don't see it, i.e., its absence may be a very poor predictor of not having a leak. And this gets at a fundamental problem when we're assessing patients with CSF leak. We have a number of tests, including brain MRI, that when they show us a positive finding, we're pretty convinced that we can rely on it to say a leak is there. But when it doesn't show us a positive finding, when it's negative, its ability for us to take confidence from that there really is no leak is really pretty limited. And so it becomes very easy to tell someone sometimes definitively you are leaking, but very hard to ever tell someone definitively when they have negative studies you're not leaking. It becomes very hard, and that presents us with a number of challenges. So this called into question the utility of brain MRI and the classic findings we've relied on for a generation. And they concluded that future research should focus on identifying more valid neuroimaging findings to diagnose intracranial hypotension, which is the brain's consequences of a CSF leak, accurately. Now, there is new research that's happened since the last time I talked to this group at the Stanford Health Library that suggests that brain MRI findings are more subtle than this acronym SEEPS, which stands for subdural pachymeningeal enhancement, enlargement of the veins, pituitary enlargement, and sagging of the brain, which is what radiologists were looking for a generation. This paper, published by Dr. Dobrocki and colleagues out of Bern, Switzerland, and subsequently referred to in the literature as the Bern criteria, B-E-R-N, looked at how measurements in the brain, subtle measurements, including the distance between the top of the pituitary gland and the bottom of this structure called the optic chiasm, where this distance between something called the mammillary body and the top of the pons, or this distance between the bone in the front of the back of the skull called the clivus and the pons, have some predictive relationship to whether someone really has a leak or not. And you can see on this MRI of someone who had no pachymeningeal enhancement, those measurements meet some of their criteria where in fact there is some enhanced likelihood that there really is a CSF leak. So these Bern criteria add something now to the brain MRI where there's kind of this intermediate sense of information coming from the brain MRI. So now when we get a brain MRI, we might be able to say, oh, it shows clear evidence of a leak. But when it doesn't show pachymeningeal enhancement, it may still have alterations in some of these measurements, which get translated into a 0 to 9 score. And based on that 0 to 9 score, you get ranked as having low probability or intermediate probability or high probability, which is fundamentally a more accurate way of using the brain MRI. It recognizes that the brain MRI is, for the majority of people, providing information about the probability that there's a leak without actually being diagnostic in the way that we've been acculturated to think of what a doctor is supposed to do for a patient. We're supposed to tell you either there's a leak or there's no leak. And this idea that we're instead going to use a diagnostic test like a brain MRI to tell you after getting the brain MRI, I'm more suspicious of a leak, but I'm still uncertain, or after I've gotten the MRI, I'm less suspicious of a leak, but I'm still uncertain. We're just not used to thinking that way. We're not used to thinking that a diagnostic test won't tell us yes or no, but will instead simply update our probability that the leak we were looking for is now higher or lower. So this brain MRI and the burn criteria that come from it is a real advance over the previous diagnostic yes-no that was largely relying on pachymeningeal enhancement, but it's still not the diagnostic test that simply tells us yes or no. And so it still leaves us with a problem. Now, the pressure of the spinal fluid has also been used to screen for a CSF leak. And we have now been learning over the last 5 years that that's really pretty terrible too. So this paper was published by my colleagues at Duke, Linda Gray and Peter Kranz, Tim Armren. And this is from an outstanding group of people who are really leading the way in diagnosing CSF leaks. And what they did is they looked at the opening pressure, the pressure inside the CSF when someone put a needle in it, in 106 patients with imaging confirmed CSF leaks at Duke's CSF leak program. So these are all patients in whom the imaging is clearly positive. Doesn't include the much larger number of patients who have symptoms but are not imaging positive. So these are what we would call the true positives. These are the people in whom we're not questioning anymore that they have a leak. And they measured the pressure in them. And for a long time, we had been taught that if somebody had a leak, their opening pressure would be less than 6. But when they actually measured the opening pressure in these people with imaging proven leaks, what they found was that 2/3 of them had pressure in the normal range, above 6. So for every one patient that had a low opening pressure, there were 2 patients who had clear imaging proven leaks that had the opening pressure been relied upon as a diagnostic tool, would have been told incorrectly that they did not have a leak. It falsely reassured in more patients than it correctly identified. And in fact, in several of the patients, not only was their opening pressure not low, they actually had opening pressures that were above the normal range. So opening pressure, like brain MRI, has come to be viewed as maybe not as reliable as we would like and previously thought. Spine MRI has also been used to screen for a CSF leak, but that's become a little bit of an issue as well. So for a long time, this test of a digital subtraction myelography, which I referred to earlier, was done to tell when somebody had a fast leak where the leak was occurring. And it would look like this. So they inject this contrast, and you see it spread in the bag of fluid here, and then you saw it kind of come out where the leak was up here. So I'll show you that again. And that would allow people to identify where the site of a leak was. Well, the colleague whose picture I showed you earlier, Dr. Shiving down at Cedars, he reported in 2014 something that had never really been reported before, which was in the journal Neurology, he reported 3 cases of examples of patients he was evaluating for CSF leaks who had symptoms of CSF leaks. And when he did that kind of digital subtraction myelography, he didn't just see spinal fluid leaking into the epidural space, but instead he saw it going off into a vein. And he named it a CSF venous fistula. I should say they named it, Dr. Shiving, Dr. Mosier, and Dr. Maya, because it was really a team effort. So, and this is what it looks like when they did that digital subtraction myelography. It showed that the contrast would fill the bag and some of these little aneurysmal things coming off the bag, but then you see these little wispy things, which are veins draining the contrast that had been put into the spinal fluid away. And you can't see it on an MRI. So here's spinal fluid leaking away into the venous system in a way that is totally invisible on a spine MRI. Now, when he reported this in 2014, I don't think a lot of us really knew what to make of it. No one had ever heard of this before or reported it before, and we assumed that it was uncommon. But the basis for assuming it was uncommon was really not a strong basis, because not a lot of people had ever undergone this kind of digital subtraction myelography. People were told if their spine MRI didn't show a leak, that they just didn't have it. So we didn't have a strong reason for believing that these things were uncommon, but we did because no one had seen them before. Well, Dr. Shivink and Dr. Farb, a radiologist, a neuroradiologist in Canada, then published this in just the last couple of years, what's called lateral decubitus digital subtraction myelography. So Dr. Farb up in Canada made the observation that if instead of doing that digital subtraction myelography when someone was lying face down, but instead did it when they were lying on their side, that he was finding more of these fistulas. So he reached out to Dr. Shivink, and the two of them together worked on this series together. And what they found was this is what a little fistula might look like when somebody gets that digital subtraction myelography when they're lying face down. But if you instead look when they're on their side, you see this. It's just much more prominent, much easier to see, because some of this contrast is getting densely into the little thing, this thing called the perineural cyst, that then leaks into the vein. And so what they found was if instead of looking with people lying face down, they did this kind of digital subtraction myelography with someone lying on their side, that instead of finding these things rarely, they started finding them all the time. Now, I told you, these things on MRI look totally normal. On MRI, what do you see? You see a vein with fluid in it. That's what veins are supposed to look like. They showed together in that paper I just showed you that if someone's brain MRI showed evidence of a CSF leak and their spine MRI was totally normal, that 75% of those patients will have a CSF venous fistula, and it is only seen when you do that kind of lateral decubitus, meaning lying on their side, imaging. Dr. Shivink then extended that work to look for fistulas in patients who had postural headaches and totally normal brain and spine imaging, okay? So let me say that again. These are patients who had postural headaches, whose brain MRI was totally reassuring, and whose spine MRI was totally reassuring. These were patients who, for a generation, expert physicians have been telling them with great confidence, you do not have a leak. We have ruled out a leak by a brain MRI and a spine MRI that can be relied upon. And what he found was that when he looked at these patients who had the right symptoms and a completely normal brain MRI and normal spine MRI, 10% will have a CSF venous fistula. And that's when we're using the technique that we've only been using for a couple of years. We don't know how high that number is going to rise as we get better and better at looking for these fistulas. It's at least 10%. And like I said, these are the people we've been telling for years with great confidence, you don't have a leak. So this patient who I first saw in 2016, whose brain MRI was totally normal, who had the elevated prolactin and the chronic nausea and had been told she had POTS. She last week had what is a modification of that lying on your side technique, where contrast was injected into her spinal fluid, and you see it now pooling here. And you see this little kind of hazy thing here, which is better seen here with this little loop around. That is a CSF venous fistula in this girl who I've been trying to help for 7 years, waiting for our imaging to get better so that we could get this image which we got last week to fix her. And this is what these advances mean. Suddenly, some of these people who have been debilitated with mysterious, unexplained headaches for years, we now have an answer for, which will lead to a cure because we know how to treat this. This can be treated either by injecting fibrin glue into this, or it can be cured by, as they have shown us from Mayo Clinic, you can thread a catheter up the vein into this and inject a little cement into the vein, or a good surgeon like Dr. Shivan can operate on that. So once you can find this thing, you know, the likelihood you're going to fix someone within the next couple of months is very high. So with that, I want to bring back your attention to the QR code I put up at the beginning, which again, right now links to a Google Drive, but it will eventually link to additional web resources that will allow you to reach out to figure out where you might contact a doctor that's interested in CSF leaks, how to reach out to make an appointment with me, how to look at the articles that I talked about, which are in the Google Drive folder shared by this QR code right now. It also has a link to the 48-hour flat test and hopefully more resources over time to come. And with that, I'm going to stop. I thank you for joining us tonight, learning a little bit more about this treatable, sometimes curable, sometimes frustrating cause of suffering for so many people with chronic headaches. And I have time for a few questions before we wrap things up.
Thank you, Dr. Carroll, for sharing this great information. And yes, indeed, there are a bunch of questions that came in. And the first one is, if a patient has all the leak symptoms and also had a positive flat test, but the MRI does not show a leak, can this patient still potentially have a leak?
Oh, yeah. So that was kind of what that last paper was showing, right? That we know now that we can definitely find a CSF venous fistula in at least 10% of those people. And in data I didn't show you, those burn criteria, those brain MRI measurements that are not diagnostic, but can give you a probability score if we look more carefully at your brain MRI, those have been shown by the group at Mayo Clinic to predict not only the likelihood of having an old style conventional spinal fluid leak, but also predict the likelihood of finding a CSF venous fistula. So your brain MRI might have been read as normal and your spine MRI may show no leak, but your brain MRI, if scored according to those burn criteria, may suggest a higher than that 10% chance of finding a CSF venous fistula. And again, we're getting better and better month by month at doing the kind of imaging to find those fistulas. We're better at it than we were last year, and I'm confident we're going to be better at it next year. And so the answer is definitely and demonstrably yes. If you have postural headache and your brain MRI and spine MRI is negative, there is some non-zero chance that we're going to find something fixable and curable. Now, 10% is not a high number, but your burn criteria, if that's a little higher, even if your brain was read as normal, that number may go up to 30%. So 1 in 3 is not bad for fixing a chronic incurable disease. So so that's where we are today in 2023. Next question.
Okay. When the site of the leak has not been found, are there treatment options?
So if the site of the leak is not found, it's clear that many people will benefit from an epidural blood patch, even if the blood patch is not done right at the site of the leak. That some of that blood spreads all over, and some people benefit from that and some people don't. So it's clear that especially if the leak is new, that kind of patch where you're not sure where the leak is, what we call a non-directed epidural blood patch, can be very useful. especially if the leak is new. If the leak has been chronic, it may be that it has to be a directed patch. There's some data that if you do a non-directed epidural blood patch, that patching more than one site, so putting a needle, for instance, in the lower thoracic spine as well as the lumbar spine, may increase the likelihood of benefit. And there's some data suggesting that higher volumes of blood are more successful than lower volumes of blood. But at the end of the day, yes, a blood patch can be helpful even when you don't know where the leak is.
Okay, next question is, does imaging require contrast, and is gadolinium safe?
So if you're looking for that sign on the brain MRI that I talked about, this pachymeningeal enhancement, that is a sign that is seen after the administration of IV contrast. So it's called post-contrast enhancement or pachymeningeal enhancement. And so we use it regularly with our brain MRIs. There are places that have said, look, we think we're good enough to see when there is pachymeningeal enhancement without using contrast, using some other specialized sequences, and they think they're pretty good at saying what they would have said if contrast had been given. That is not the way most expert centers practice. And in fact, my opinion on this has been, it is such a devastating blow to the patient's health if they had the changes in their brain that would have shown pachymeningeal enhancement if you used MRI contrast, but you elected not to, and their brain was therefore read as negative in error, that has such long-term potential consequences that I think the risk of missing the diagnosis because you didn't use contrast outweighs the risk, whatever that might be, of giving contrast. Now, the next question is, what are the risks of giving contrast? So gadolinium is a heavy metal, and it is clear that there are some risks with gadolinium, especially in people who have kidney dysfunction. It can lead to some unusual conditions in people with kidney dysfunction. And there's some studies of patients who have had repeated gadolinium MRIs, for instance, cancer patients who are dying with cancer, to have their tumor staged by multiple MRIs with contrast, sometimes as many as 50 MRIs. When those patients die and they look in their brains, they can see some evidence of gadolinium deposited in certain parts of the brain, which is on its face concerning. Like, if you get a ton of gadolinium, it's clear that it doesn't just all wash out. Some of it stays there, and it doesn't just stay there. Some of it stays there in your brain. Now, those patients weren't complaining of having new neurologic symptoms. So there's no neurologic consequence that has been tightly tied in a way that we can rely on to those findings of some gadolinium in the brain. But I think just the fact that you can have a heavy metal with repeated gadolinium contrast administration start to accumulate in your brain has made all of us think, and I think all of us should think, is this really something that is worth doing? There's more controversy about whether gadolinium should be injected directly into the spinal fluid, where it then can be in much higher concentration. And it's clear from published literature that there are some leaks that you can find only if you put gadolinium contrast into the spinal fluid. And it is equally clear that many people will not do that because of the concerns that I've just mentioned about accumulation of gadolinium. And it's clear if you accidentally inject way too much gadolinium into the spinal fluid, you can really hurt someone badly and immediately. And so the administration of gadolinium into the spinal fluid really should only be done by people who have a lot of experience with it And when the consequence of not finding a leak is really going to be devastating. So, but I've seen a lot more people. I've seen many, many more people be harmed by our failure to find a leak than people who have had any kind of problem from gadolinium. So, it's always weighing risks versus benefits.
Dr. Carroll, do you have time for one more question?
Yeah.
Okay. This one is, can chronic migraines cause leaks?
We don't think chronic migraines cause leaks. So there's a couple things to realize. Depending on the age of the person you're looking at, the lifetime prevalence of migraine. So migraine prevalence is a function of age of the patient, and it can often, it has a distribution over the lifetime. And, if you're looking at, for instance, young women, the prevalence may be between 20 and 30%. And so if you're talking about among the whole population of us, maybe up to a fifth to a third of people can have migraines. The leaks that do happen are going to sometimes happen to people who have pre-existing and coexisting migraine, right? And so one does not exclude the other. And it turns out if you have a vulnerability to migraine, there's all kinds of data suggesting that if you have a chronic painful stimulus to your head, neck, or face, that can, for some people, be a potent trigger of migraines. And so somebody who has a CSF leak causing them chronic head pain can also have intermittent or episodic migraines on top of that. And whether, in fact, it is a cause for chronic migraine is, I think, still a subject that has to be dealt with in research over time. So you can have migraines, and you can have a leak, and you can have a leak and have migraines. We don't think migraines cause leaks, except here's the exception to that, all right? Somebody has episodic migraines, and one day they have the worst headache of their life. And it's so bad they go to the ER. And the ER says, oh, this is the worst headache of their life. I know they have migraines. Do we need to, but this is so different from all their other migraines. Do we need to do a lumbar puncture to make sure they don't have meningitis or they haven't had a subarachnoid hemorrhage? And then they stick a needle in their back and they have a little trouble doing the lumbar puncture to look at the spinal fluid, and they put it in a couple of times and they accidentally put it through the front of the bag too. And now they've got 3 or 4 punctures in their bag. And now they have a CSF leak that was caused by the fact that their migraine met a doctor trying to help them with a needle. And of course, when they show up the next day saying my headache's even worse, nobody thinks that it's from the lumbar puncture. They think it's from the terrible headache that brought them to the ER in the first place the day before. And so they don't often get early patches. So I've seen the confluence of people who had chronic headaches then wind up with a CSF leak as a result of their chronic headaches, but usually only with the assistance of a well-meaning doctor trying to help them or keep them safe.
Great. Thank you, Dr. Carroll, for all the great information. And thank you to our audience for joining us and for the great questions that you sent in. If you'd like additional information or resources, please contact the Stanford Health Library. We hope you'll join us on next lecture. Thank you and good night.
Thank you. Bye-bye.
Bye-bye.